Hi, class. This is Dr. Weaver, and today we will be covering Chapter 31, and this is dealing with care of patients with infectious respiratory problems. So what I would like for you to do at this moment is to take a look at the objectives. After we finish this lecture, these are the actions I would like you to be able to perform. One of which being collaborate with the interprofessional team to coordinate high quality care and promote gas exchange in patients with infectious respiratory problems. And go ahead and take a look at the rest of these objectives. There are four total. Priority concepts in this chapter the priority concept for this chapter is gas exchange, and of course that's pretty obvious. Gas exchange concept exemplar is pneumonia. The interrelated concept in this chapter is immunity. Immunity concept exemplar is tuberculosis. So one of the first respiratory ailments that we will discuss is seasonal influenza. This condition is highly contagious. It is a highly contagious acute viral respiratory infection, rapid onset of severe headache, muscle ache, fever, chills, fatigue, weakness, anorexia. Other signs and symptoms are sore throat, cough, watery nasal discharge is possible, fatigued. These patients are fatigued 1 to 2 weeks after acute period of illness. Vaccinations are advisable. Vaccinations are advisable. Antiviral agents may be effective if started within 24 to 48 hours of symptoms. Now, the seasonal influenza, this epidemic is actually pretty common, and it does lead to complications such as pneumonia or death. Those who are elderly or immunocompromised are at greatest risk of developing or acquiring this condition. Now, the flu virus is caused by several virus families. That is the A group, B, or C, and it is the B group strain that results in nausea, vomiting, and diarrhea. Now, adults are contagious from 24 hours before signs and symptoms occur and up to 5 days after they begin. As far as health promotion, vaccines, they do change every year based on the strain likely to cause illness in flu season. The recommended influenza vaccination is given intramuscularly, and that is fluvirin, and also Fluzone. It is strongly advised for the following groups: adults greater than 50 years of age, adults with chronic illness or immune compromise, and those who are living in institutions. It is advisable for healthcare professionals with direct patient contact or care, those taking care of family members with health issues. Now, we must teach these patients the importance of hand washing, especially after they blow their nose and also when they're sneezing. And there's some additional information in this section for you to look at. Other precautions when a patient is sick, they should stay home. They should avoid crowds, etc. Some additional information there. The CDC recommends sneezing and coughing into the upper sleeve, such, rather than the hand, since most people cannot conveniently wash their hands. So you want to, of course, put those germs in the sleeve rather than on the hands where you're touching different things and contaminating others. Now, a special note here, respiratory droplets on the hands can contaminate surfaces and be transmitted to others. So again, a sneeze in your shirt sleeve. As far as interprofessional collaboration, there is a test called the RI, D as in David, T as in Tom test, which is used to test patients for the flu. There actually has been many false negatives with this test, meaning patients are actually positive. So for that reason, many patients are usually diagnosed based on signs and symptoms. Antibiotics are not effective against the flu. That we do provide them with antiviral agents such as Tamiflu, etc. There's some additional ones, which is effective in prevention and treatment of some strains of influenza A and B, especially for those patients who are high risk for complications. These drugs shorten the duration of the flu, so they can still get the flu, but the duration of this condition will be short. These drugs work by preventing spread in the respiratory tract by inhibiting a viral enzyme, which allows the virus to penetrate respiratory cells. We also want you to note that one of the antiviral agents, Zamavir, you want to use with caution in patients with a history of COPD or asthma. Patients older than 65 are treated with antivirals to decrease their risk for hospitalizations, for complications, and disability. As far as recommended supportive care, we want to encourage rest for these patients for several days. We want to also increase their fluid intake unless fluid restrictions are in place for some condition, let's say, for example, heart failure. Also, these patients should gargle with saline washes to relieve sore throat, and antihistamines for rhinorrhea should be given as well. So one of the pandemic influenzas, or actually we're getting ready to discuss pandemic influenza, mostly prevalent among animals and birds. Now, when this virus actually mutates, it can cause human beings to become infected. Examples of the pandemic influenza virus is swine flu, also called H1N1, and also bird flu, aka H5N1. Now remember, strict isolation precautions should be initiated because this virus is very contagious. Some of the antiviral drugs, Tamiflu and Zanamivir, can be used as well. Now, it is called a pandemic due to its potential to spread globally, and the virus is also new to humans who are without immunity to the virus. Swine flu actually mutated and became highly infectious to humans. Seasonal vaccines contain the H1N1 antigen. And the bird flu, or the H5N1, or also known as the avian influenza, infected millions of birds in Asia and now spreading by human to human contact. A little bit of information there for you. Now, as far as health promotion, the recommended approach for any pandemic is early recognition and implementing community and personal quarantine. So basically social distancing behavior to decrease viral exposure. In areas where the infectious rates are high, All non-essential public activities should be stopped, such as attendance at schools, shopping, etc. Traveling to and from affected areas should also be forbidden. Also, adults should stay home. They should use food, water, and drugs. They should stockpile drugs for at least 2 weeks per person during a pandemic. Now, adults should pay attention to public announcements and early warning systems for disease outbreaks to stay informed. Influenza pandemic is a disaster. It is the responsibility of all adults to contain it. So it's up to all of us to contain this health concern. As far as interprofessional collaboration, it is important to support the patient, also to prevent spread of disease for patients with the avian or any pandemic influenza. The initial signs and symptoms of avian flu is cough, fever, and sore throat. Then it will progress to shortness of breath and also pneumonia. These patients also experience vomiting, diarrhea, abdominal pain, and bleeding from the nose and gums. If these patients travel to areas affected by H5N1, we want to place them on airborne isolation, place them in an airborne isolation room with negative air pressure, or you know me, I usually put some of these initials. I put PSI, which means pressure, and they should remain there until the diagnosis of H5H1 is ruled out and they're not contagious anymore. The diagnosis is made based on signs and symptoms and also positive testing. Now, direct care workers should wear personal protective equipment. They should wear fitted test respiratory type of equipment. Use airborne, droplet, and contact precautions. This is a very contagious virus. If the healthcare professional took care of patients, they should watch for any illness times at least a week, especially respiratory conditions. So these are things they should be watching for. Now, Tamiflu and Relenza should be started within 48 hours contact with an infected patient, and that should help minimize or prevent this infection, at least we hope. The healthcare provider who work with patients suspected of having avian influenza should receive the vaccine. They should receive the vaccine in the recommended process or steps. So there's essentially some steps to this process when receiving this influenza vaccination. Treatment includes supportive care. These patients should be provided with oxygen for hypoxia and respiratory compromise. They should also receive respiratory treatments. They might be also intubated. Sometimes this condition can become pretty severe. Antibiotics is given to treat bacterial or secondary infections from this condition or associated with H5N1. IV fluids should be provided for treatment, especially for diarrhea. We should also be doing a strict intake and output and just basically monitoring their hydration status. So 2 important areas to monitor during rehydration. We want to look at their pulse rate, the quality of the pulse, as well as their urine output. So the next topic we will discover as a gas exchange exemplar is pneumonia. also abbreviated P as in Paul, N as in Nancy, A as in Apple. It is excess fluid in the lungs resulting from the inflammatory process. The inflammation is triggered by infectious organisms and inhalation irritants. There are four types of pneumonias that we will discuss. There is community-acquired pneumonia, or CAP, C-A-P. There's also hospital-acquired pneumonia, and that is HAP, H-A-P. There's also healthcare-acquired pneumonia, and that's HCAP. And there's also ventilator-associated pneumonia, so we won't discuss that one too much. Actually, I think I gave you a chapter to kind of skim through some of that information. As far as the pathophysiology of pneumonia, essentially gas exchange is compromised. In gas exchange, O2 is carried to the cells to enter into our bodies, of course, and of course CO2 is carried away from the cells via ventilation and diffusion process. Now, inflammation affects the interstitial spaces, the alveoli, as well as the bronchioles of our lungs. As far as the process of pneumonia or how it takes place, organisms penetrate the airway mucosa, and it multiplies in the alveolar space. Then we have white blood cells travel to the localized area, which results in a local capillary leak. This leak will lead to edema and also exudate or pus. Now this will lead to fluid collecting in and around the alveoli, and this will also in turn lead to alveoli wall thickening. And these events actually decrease or reduces gas exchange by interfering with that diffusion process I just discussed of CO2 and also O2. This will, of course, lead to hypoxemia. Remember, hypoxemia is a reduction of oxygen in the blood, whereas though hypoxia, or someone who is hypoxic, is a lack of oxygen in the tissue. This can lead to death as a result. Now, in addition to this process, you also have red blood cells and fibrin that also move. This is all a part of the inflammatory process, but the red blood cells and fibrin move into the alveoli and capillary, which leads to infection to other lung areas. So the infection can spread to other lung tissue. Now, this infection or these microorganisms can leak into or get into our bloodstream, which can also lead to septicemia. Now, if the infection leaks into our or the patient's pleural cavity, this can lead to what is referred to as an empyema. This is essentially a collection of pus in the pleural cavity. Also what happens, fibrin and edema causes the lungs to become stiff. So you don't have that elasticity of the lungs, but they become stiff, so they have decreased compliance. There's decreased compliance. There's also a decrease or reduction in the vital capacity. Also, the alveoli collapse, and this is also known as atelectasis. And this can lead also to a decreased gas exchange, which also can lead to a decrease in arterial oxygen, resulting in hypoxemia. Now, what also happens is pneumonia occurs as lobar pneumonia with consolidation. Essentially solidification or lack of air spaces, which is kind of your definition of your consolidation. And this happens in certain parts of the lungs, or as bronchopneumonia with diffusely scattered patches around the bronchi. And this also depends on the patient's health status as far as their immune system. And so this can also lead to an abscess and also perforation of the bronchial walls. And this is as a result of tissue necrosis. Now, as far as the etiology, I want you to read table 31-1 on page 599. And this just talks about some risk factors for pneumonia, for CAP as well as HCAP types of pneumonia. Now, when the immune system isn't strong enough, the invading organism takes over, resulting in pneumonia. Now, pneumonia can be caused by bacteria, viruses, and fungi, and there's some additional organisms as well, so take a read of that. And as far as non-infectious causes, there is the inhalation of toxic gases, chemical fumes, and also aspiration, and there's some additional information for this as well. Also, see, like my phone is going off, so give me a moment. So I want you to see categories of pneumonia in table 31-2 on page 600 of your textbook. As far as incidence and prevalence, the rate of pneumonia is higher in older adults, patients also who reside in nursing homes. There's also some additional places where you can find a higher incidence of pneumonia. So just take a read of that. The CAP type of pneumonia does occur more, or community acquired pneumonia does occur more than the hospital acquired pneumonia. The former or the community acquired pneumonia is frequently a complication of influenza. So this is why it's so important to get these patients vaccinated. As far as health promotion and maintenance, patient education is important for pneumonia prevention. Pneumonia vaccinations especially are important for those who are 65 years and older, people with chronic health issues. There are two pneumonia vaccinations, one being the Pneumovax and the other one being Prevnar 13. Those are the two. Now, on page 599, there is some recommendations from the CDC. I want you to take a look at that as well. Now, older adults should especially receive the seasonal influenza vaccination, since pneumonia is pretty common. It's a pretty common complication of that type of flu. Now, also read chart 31-1 on page 600 for patient and family education for how to prevent pneumonia. Now, the Joint Commission, or TJC, they recommended that acute hospitals offer pneumonia vaccines to patients, but compliance has been pretty poor. Essentially, when your patients are in the hospital and you're doing your admission profile, there is some options on there to discuss with the patient about receiving these vaccinations, pneumococcal and the one for the flu. And you have to show this in your documentation whether or not the patient accepted the vaccination or they refuse. As far as recommendations for prevention, we want to teach strict hand washing, avoid large crowds during the cold and flu seasons, etc. There's some additional information there for you to read. Respiratory equipment should also be maintained well, and sterile water should be used over tap water for GI tubes and for GI tubes, and also aspiration precautions should be instituted, and other ways to prevent this complication of aspiration. Also take a look at chapter 32 for prevention of VAP or ventilator-associated pneumonia. And just skim through this section for now. Don't read it too much in depth, because I believe you all will be seeing this again in multi-systems. So let's go ahead and take a look at the assessment section as we continue to look at pneumonia. We want to focus on the history, physical assessment, laboratory assessment to include gram stain culture and sensitivity of sputum, and also imaging assessment such as the chest X-ray being a great tool to evaluate for pneumonia. So keep in mind that signs and symptoms of older patients differ from younger patients with pneumonia, something to look for. Also, I want you to take a look at the concept map on page 602, which actually addresses assessment and nursing care issues related to patients with pneumonia. As far as the history, I want you to look at, first of all, page 601, table 31-1 for risk factors for pneumonia. Also, read the pertinent history questions you want to ask these patients on page 601 also. These questions will help you to focus your assessment and use the right concepts, the right medical terms and so forth, and looking for the right things for these patients with pneumonia. As far as physical assessment, i.e. signs and symptoms, we're looking for signs and symptoms of flushed cheeks and anxious expression. Also, we're looking for chest pain, headache, fever, etc. So there's some additional information on page 601. We want to look for to see if the patients are using accessory muscles of respiration. These patients with hypoxia, they have hypoxia. They also have decreased gas exchange, and they're not comfortable lying down. And so they will assume what is called a tripod position. I believe the book may give you a depiction of what a tripod position looks like. It's the same position that people with emphysema also assumes when they're trying to position themselves in a way that they can breathe a whole lot easier. We want to also assess the characteristics of the sputum, if it's green, if it's thin, if it's tenacious, also if it's purulent, pus basically, a form of sputum as well, which can indicate a bacterial type of infection, if hemoptysis is also present. Also, we want to want you to read why crackles, wheezing, bronchial breath sounds, and fremitus are heard in patients with pneumonia, and you can take a read of that on page 601. These patients, they would have chest wall expansion, or the chest wall expansion will be either decreased or unequal on inspiration. All right. We want to pay attention to baseline vital signs, especially in the elderly. With pneumonia, these patients tend to be hypotensive, or there are some orthostatic changes due to dehydration largely, and also vasodilation. And so when you look at the quality of their pulse, the pulse will be a rapid, weak pulse. Now, this can be indicative of hypoxemia, dehydration, or septic shock. Because of hypoxic cardiac tissue, these patients, you might see dysrhythmias. Also take a look at page 603, table 31-3, for the patho of common signs and symptoms of pneumonia. Tells you why these patients are having the different signs and symptoms. And again, look at page 603. Also, the clinician might use the pressure or curve -65 tool to determine where patients with pneumonia should be treated. And it provides information about what data is reviewed. When I say where these patients should be treated, I'm essentially talking about whether or not they should be treated in the acute hospital versus the community setting. And you can find this information on page 603. As far as psychosocial assessment, we want to make sure that when we are interviewing these patients, you want to give them a break because they will speak with broken sentences due to the fact that there is this airway obstruction from the pneumonia that they're dealing with. And they also are fatigued. There's this muscle fatigue that they experience as well. So just make sure you're very considerate of these patients while you are interviewing them. As far as the laboratory assessment is concerned, your physician may order, or your healthcare provider will order, a gram stain, a culture, and sensitivity of the sputum in order to determine what is the causative organism so that the appropriate antibiotics can be employed. Specimens are given by way of a patient can cough up sputum, or also you can suction these patients if they're too weak to actually cough. If you look at figure 31-1, you will see how the sputum is trapped using a device with a suctioning apparatus to obtain the specimen. We also want to obtain a CBC. In particular, we want to look at the white blood count to determine if a infection is present. Of course, this might not be helpful in the elderly since their immune system responds pretty poorly. Blood cultures are also obtained to see if the organism, if this organism has entered into the bloodstream, and of course treated with the correct or proper antibiotics. These patients also may have an ABG to determine what their arterial O2 levels are, and if supplemental O2 is needed. More than likely, supplemental O2 will be needed. A BMP lab can determine if there is dehydration by looking at the BUN and other electrolytes. They can also look at the serum osmolarity to determine hydration status. And also your doctor or your healthcare provider may want to obtain lactate levels to assess for sepsis. Usually when your lactate levels are increased, these patients, they're possibly septic at that point. As far as imaging assessment, chest x-ray is the most common test for pneumonia, but may not show changes until 2 or more days after signs and symptoms have appeared. And basically it shows up on the x-ray as increased density. In a lung segment, well, this will show in a lung segment, perhaps in a lobe, maybe in one lobe or possibly both lungs. If it's in both lungs, we would refer to that as a bilateral type of pneumonia. The chest x-ray is essential for the elderly due to the vague symptoms these patients will have when they present with pneumonia. So it would be a very useful tool for these patients. A pulse ox can determine if there is hypoxemia present. And these patients also might develop a pleural effusion, and so a thoracentesis would be appropriate for these patients. Now, I would like for you to read the priority problems for pneumonia on page 603 and its related tools. You'll see some related tools, for example, potential for sepsis related to the presence of microorganisms in a very vascular area and decreased immunity as well. And so some of the Some of the nursing diagnoses that you can use is decreased gas exchange, potential for airway obstruction, potential for sepsis, potential for pulmonary emphysema. So these are some of your nursing, some of which you can use as a nursing diagnosis. So as far as planning and implementation, essentially responding, we want to improve gas exchange, of course, by providing oxygen therapy and also considering incentive spirometry usage. Also, we want to prevent airway obstruction, prevent sepsis, and prevent or manage these patients who have emphysema. So to improve gas exchange, we want to, again, administer oxygen with nasal cannula or mask, whatever's appropriate, and to assist these patients with bronchial hygiene. An incentive spirometer can improve inspiratory muscle action, and it prevents or reverses atelectasis in the alveolar collapse. So when your alveolar collapse, it can prevent that as well. I would like you to look at or to see the intervention section of improving gas exchange for additional information. Also, there is some instructions. Let me see if yes, all right. So look at the instructions also in that section on how to use an incentive spirometer. Some people might blow in the incentive spirometer, but I want you to take a read at that information. We also call it an incentive spirometer an IS. That's the abbreviation that you might see in the clinical setting. So you want to be able to evaluate their technique and also record their volume if air is inspired. As far as preventing airway obstruction for pneumonia, such as COPD or asthma, obstruction results from these patients being, or what we consider being fatigued. There's muscle weakness, chest discomfort, and excessive secretions these patients have difficulty clearing. The nurse should help patients to cough and deep breathe at least every 2 hours. Again, use their incentive spirometer. Also, we want to encourage coughing. As I mentioned, drink at least 2 liters of fluid if this, in order to prevent dehydration and also thin their secretions. Helps to mobilize their secretions a whole lot easier. And of course, obviously, as long as this is not contraindicated. Contraindicated if a patient has a renal disease, severe renal disease or heart failure, then there's usually some kind of fluid restriction. So restrictions such as that. We want to also monitor their intake and output, their oral mucosa for, again, we're looking for signs of dehydration or monitoring their hydration status. We're also looking at skin turgor for hydration status, especially when these patients are febrile, they're tachypnic, signs and symptoms. These patients might be provided with bronchodilators, IV steroids, and also guaifenesin are used to decrease obstruction. As far as preventing sepsis, as you know, these patients might be placed on anti-infectives to treat the infection in pneumonia patients, except those patients who have a viral kind of pneumonia. We usually use antibiotics for bacterial type of pneumonias. And so the drug that is used, the route of administration does depend on how the patient acquired pneumonia, such as the community acquired pneumonia versus the HAP type of pneumonia or hospital acquired pneumonia. It also depends on the severity of illness, the organism involved. or if the patient have conditions that increase the risk of complications, such as decreased or reduced immunity, etc. So there's some additional information to see in this section as well. We also want to consider drug-resistant organisms. Uncomplicated CAP is actually treated for 5 to 7 days, and patients with severe impaired immunity, or if they have a HAP type of a pneumonia, for 21 days. All right. So CAP is treated for 5 to 7 days. Hospital-acquired pneumonia, 21 days. So keep that in mind. We also want to observe and prevent aspiration pneumonia, aspiration of foods and stomach contents. Aspiration of stomach contents can lead to a widespread inflammation. It can lead to ARDS and also permanent lung damage. So aspiration precautions is extremely vital. We want to also prevent and manage emphysema, a collection of pus in the empyema, excuse me, I was probably saying emphysema, but it's empyema, my apologies. A collection of pus in the pleural space is mostly due to pulmonary infection resulting in decreased gas exchange by decreased lung diffusion and also a decreased effective ventilation. The empyema, if empyema is suspected if there's a decreased chest wall motion, if there is decreased fremitus or absent. Percussion, excuse me, it's normally has a flat kind of, that would be as far as when you percuss, when doctors percuss these different areas, it would have more of a flat a sound to it. And also there may be decreased breath sounds. Also, patients, they will have abnormal breath sounds, which could indicate bronchial type of breath sounds. They may have what we refer to as egophony, and whispered pectoriloquy is also present. You'll learn about these types of breath sounds when you get into term 6, I believe, in health assessment. So just know the terms for now. Also, empyema fluid is very thick. It is opaque and is exudative with a foul smell. Diagnosis is made with a chest X-ray or CT of the chest and a sample of the pleural fluid via a thoracentesis. So a thoracentesis would have to be performed to obtain that specimen. Treatment for empyema is to drain the empyema cavity, to re-expand the lung, to control infection, antibiotics. Chest tubes do promote lung expansion and also drainage. Surgery is sometimes needed if the purulent matter or the pus is thick or excessive pleural thickening. So surgery might be required then. I think they might do like a pleurodesis, if memory serves me. So on the care coordination and transition management for pneumonia, I would like for you to read page 605 to look at home care management, self-management, education, healthcare resources, i.e. prevention, immunization of appropriate persons, which we discussed earlier. As far as home care management, patients may need to reside on the first floor of a 2-level home due to compromise of their pulmonary condition. Just trying to negotiate stairs and whatnot might be a bit much for these patients who are having a respiratory condition, a deterioration or compromise. Also take a look at chart 31.2 on page 605 for a focused assessment for patients recovering from pneumonia. As far as self-management education, obviously we will be doing some drug teaching, side effects, mechanism of action, what to report to their physician, especially if they're having adverse impact from the drug. We want to also teach them to complete all of their anti-infective medications as prescribed. That's what that RX means, as prescribed. We want to teach them to notify the physician if a fever, chills, hemoptysis, etc., develops, and if it doesn't go away. So make sure you're teaching them to report those issues. We want to also encourage rest. The patients and family should avoid upper respiratory infections and viruses, so you want to avoid crowds, especially in the fall and the winter period. You want to avoid people who have colds, who have the flu, and exposure to irritants like smoking or smoke from smoking, and also encourage a healthful diet that is well balanced is important as well. As far as health care resources, smoking prevention certainly is paramount here. And we want to also provide resources on local smoking cessation classes, and also nicotine replacement options, patches is something to look at. Also resources regarding pneumonia, the flu vaccination is also important, as these vaccines do boost immunity to these conditions. And on page 605, I want you to read the evaluation and reflecting section, and this is what we will be evaluating in this patient with pneumonia.